Thanks, Sophie. And thanks so much for having me come and talk to you about the ethics of patient-centred care, the right to health and the social contract. I'd like to start by talking about Louisa, who was a beloved person who had cancer who spoke at a parliamentary event in 2015. And Louisa said this: "I'm a hard-working, tax-paying Australian whose greatest goal in life is to live long enough for my 2-year-old daughter to remember me. We have to find a way to make this process faster so that whether we live or die is not determined by the size of our bank balances." Sadly, Louisa died not long after she gave that presentation. And 6 years later, in 2021, rare and less common cancers still cause about 50% of all cancer deaths in Australia each year, but only attract around 10% of research funding and a fraction of drug funding each year. How do we fix this? Everybody's talking nowadays about patient-centred care. But what does that mean? What are the rights of patients? And what are the obligations owed to them? And who owes them? The right to health is at the core of our medical system. It's a recognised human right, which arises from a human rights treaty called the International Covenant on the Economic, Social and Cultural Rights. The right to health is stated like this: the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. The highest attainable standard. You're going to hear that a lot today. Now, there are lots of laws in Australia about health, privacy laws and laws about medication and consent to make sure that basic legal requirements are met. But today we're looking beyond these laws to what patients can expect from the healthcare system. What is fair and what is ethical? So the main ethical principles that we think about when we're talking about healthcare are justice, non-maleficence, beneficence and autonomy. When we are talking about justice and the right to health, the term we usually use is distributive justice. Now this relates to ideas of equity and access and fair distribution of resources. The National Oncology Alliance has defined equity in cancer care to mean this: all patients have access to the best therapies, technologies, care, medical networks and social supports when they need them at an affordable price, regardless of geographic location or socioeconomic status. This means that no matter who you are, where you come from or how much money you have, you should receive the same level of care. Non-maleficence refers to the idea of doing no harm, so the obligation to leave a patient no worse off. Now there are some things, like chemotherapy, that feel like they might be in conflict with non-maleficence. But these ethical principles aren't always either or. They're always a balancing act. And generally, the idea is that patients shouldn't be left worse off by their treatment or their interaction with the medical profession. Beneficence is about acting in the patient's best interest. But how do we figure out what's in the patient's best interest? Medical professionals have a lot of knowledge and expertise, but generally they don't share the life experiences of people with cancer. And so there are a whole heap of things that we have to take into account to ensure what's being done is in the best interest of the patient. When Rare Cancers recently spoke to patients about what they said they needed, here are the things that they said. Better information and communication about treatment. Only 30% of patients said that they were receiving enough information after their diagnosis. Continuity of medical practitioners and the assignment of a consistent care navigator. This is someone who's assigned to every patient to manage their appointments and their medical professionals. Communication between providers, both within and outside of hospitals. Equitable access to treatment options, hospital care, drugs, medical trials. Financial support. About half of patients said that they were under significant financial stress after their diagnosis, and this isn't in patients' best interests. And ongoing support for longer-term health issues, which is a big issue for survivors. This brings us to autonomy. When we hear the word autonomy, it usually makes us think about consent and being able to say yes or no to treatments. But autonomy is about more than just consent. It's about being involved in treatment decisions. This means patients can make informed decisions for themselves, but also to be involved in broader policy making. Patients want to be involved. They want to share their insight and bring about the best outcomes for other patients as well. Another document that sets out rights for patients is the Australian Charter of Healthcare Rights. This is a new document that was released in 2019. and it's supposed to have an increased focus on person-centred care and to empower consumers to take an active role in their healthcare. The Charter says that patients should have the rights to access to healthcare services and treatment that meets their needs, ongoing support for longer-term health issues, to be able to make decisions and include people they want in decision-making and planning, and to have clear information about their condition, possible benefits and risks of different tests and treatments to make informed decisions. So the Charter says all the right things, but how's it carried out? What makes all of this happen? Obviously, the medical profession is tasked with implementing this Charter, and the understanding of this relationship between the profession and society has been given this term, the social contract. Just briefly, a social contract is a relationship between citizens, the government, and institutions in a society, where each one has responsibilities and each enjoys freedoms as a result of being part of this relationship. As part of the contemporary social contract, individuals give up some freedoms, like the freedom to harm other members of society, to gain freedoms, like the safety of being in society where others can't harm them. And this social contract idea applies to medicine and the right to health. Under this social contract, the medical profession and patients both have rights and responsibilities. The medical profession enjoys a monopoly on providing healthcare, has autonomy in carrying out their professional duties, and has the ability to self-regulate the profession. In turn, society expects a high level of competence, altruism and integrity in delivering healthcare services, as well as a centering of the public good. But this understanding of the social contract only considers medical professionals and the individuals that make up society. And this is the kicker. Someone has to pay for all of this. In Australia, we have universal healthcare. We pay our taxes, and in return, we expect things from the government. What's the role of the government in this social contract, in upholding the right to health, the right to the highest attainable standard of physical and mental health? So in the healthcare setting, the social contract is actually a tripartite contract between patients, the medical profession, and the government. There are some other institutions that might also have a role in the social contract, like pharmaceutical companies, but for today we'll focus on these three. We're speaking a lot about patient-centred care, and to achieve what we mean when we talk about that, we need to look at the social contract to see where the roles of each party fit properly. All of the parties need to fulfil their roles and obligations for this to all work properly. Let's start with patients. What are the obligations of patients in this social contract? Firstly, they pay their taxes. They abide by the rules and regulations set down by the government, and they put trust in the medical profession and the government to do what's right. Now, this level of trust shouldn't be taken lightly, and underlying trust is absolutely integral to the functioning of any social contract. When patients go to the doctor or submit to treatment by a professional, they are giving up a few things, like their ability to make other choices about their healthcare, and often accepting harms, trusting that in giving up those freedoms, they will be better off in the long run. This trust from patients should increase the importance that's given to each and every treatment decision. Next, we come to the medical profession, which is where patient-centred care comes in. The Institute of Medicine has categorised person-centred care into 6 domains: being responsive to patient needs, values and preferences, integrated and coordinated care, relieving physical discomfort, providing emotional support, involving family and friends, and the provision of information, communication and education to enable patients to understand and make informed decisions about their care. These 6 domains should be the bread and butter of medical care. And so many medical professionals do all of these things so well. But many of these, and especially the last one, are the source of a lot of difficulty for patients. When Rare Cancers asked people about their experiences, this issue of being provided sufficient information came up again and again, and this is just one quote that we heard. Patients should have to be informed about the trials that they qualify for. My husband and I specifically asked my oncologist about immune therapy trials for triple-negative breast cancer. We were very keen to try it. Despite an hour-long discussion about it with the doctor and her nurse, assuring us that they were on top of trials and there were none that I could join, my husband and I learned about a trial that was exactly on point for me. By the time we learned of it, it was too late, as I'd undergone treatment. When asked about it, my doctor admitted that she knew about it but made an excuse why she thought I wouldn't like the trial. It was my decision to make. I should have been informed. It was disempowering to have her withhold such important information. This brings us to some more ethical concepts: paternalism and informed consent. Paternalism is this idea that we know better what is best for you. Now, sometimes this is the case. You might remember the obligation of beneficence is about acting in the patient's best interests, and doctors have to make very difficult decisions about this all the time. And some laws are paternalistic, like seatbelt laws or requiring motorbike riders to wear helmets. But the idea that medical professionals should choose which options they present to their patients and which opportunities they let them know about is highly paternalistic and isn't in patients' best interests. It's out of keeping with this modern social contract and the trust that's been put in the profession. Patients expect to be informed. They're giving up freedoms to submit to treatment and endure possible harm, or maybe even believing there is no treatment available, when in fact there might be. This ties in with the key idea of consent, which is vital to the social contract. Thinking that you know what's best for someone isn't enough to gain their consent for something. You need to take them with you. Informed consent isn't just a matter of sticking a consent form under someone's nose and making sure they sign it. It means taking the time to truly lay out the options, providing all of the relevant information. It means putting the person at the centre of the conversation. Finally, that brings us to the government. The government has a significant level of power in the social contract and therefore big obligations. It's not enough for the government to build hospitals and train doctors and say, we've dealt with the right to health. That might provide for basic levels of healthcare, but it doesn't provide the highest attainable standard of health for everyone. The government has promised to deliver that to us as a human right. Now, we know that the word attainable puts some limits on what's possible. The government can't pay for every drug that exists in the market for every patient. But that doesn't let it off the hook. It can streamline its processes to ensure that drugs that do exist are given fast-tracked approvals. We hear again and again of the comparisons between the time taken in Australia for approvals compared with other countries. At the end of the day, patients are taxpayers, patients are constituents, and it's a patient's right to be able to have broad access to treatment in under 100 days from registration. We see it happening in other countries. There's no reason why it shouldn't be happening in Australia. If you're looking at the countries that we're comparing to, France, the UK, Germany, Switzerland, countries that we like to think we have an equivalent standard of life to, an equivalent society. Yet here they are, 40 countries down the track, and the drug is not available. And it's available in other places. And there are innumerable examples, not one or two. It doesn't matter what persuasion the government is. The fact is, we're a Western society in a developed country with a high GDP per patient, and we shouldn't have to ration drugs like we do. Health is a right, not a privilege. The government can prioritise funding where it's lacking. It can provide sufficient resources. It can support and fund adequate care navigators for every patient, as I talked about earlier. Navigators in oncology aren't a new idea, and research has already shown significant benefits to assigning navigators: shorter time to treatment, increased patient and caregiver knowledge, better adherence to care, and improved quality of life. And we're also seeing cost benefits to healthcare institutions through emergency department visits being reduced and readmission rates. Some hospitals that are large tertiary institutions have access to navigators for every person who's been diagnosed with cancer. Wouldn't it be amazing if they were available to all patients, regardless of what hospital they attend? They are all taxpayers. They all have a right to the correct information. Across the board, you'll see that language of the social contract is emerging. Members of society pay their taxes. They have a right to this highest attainable standard of health that the government has promised. If the government doesn't uphold its obligations under the social contract, how can medical professionals provide access to the highest attainable standard for all patients? If MSAC applications take years to progress, if medications that are approved for one cancer type can't be used for another without impenetrable red tape, ultimately leaving patients to die while waiting for approvals, how can the profession provide the required level of care?
So when you're sitting on the
Remember
panel,
Louisa, who I spoke about at the beginning of the talk?
We're waiting for the VT.
I think Louisa would expect that the average Australian would expect that after faithfully paying their taxes, participating in society, and playing their part in the social contract, that when the worst happens, and they're found not only to have a cancer diagnosis, but to be told it's a diagnosis for a cancer that no one knows much about, that they won't be hung out to dry by the government because their cancer is rare or less common. That their right to the highest attainable standard of health, I told you you'd hear that a lot, applies equally to everyone, including those whose cancers haven't received enough research funding. Maybe their treatment options are limited, but if they're limited because of bureaucratic delays, mismanaged budgets, or inefficient approval processes, that is a tragedy. COVID-19 has devastated healthcare budgets, all budgets, no question. But healthcare isn't an either-or. People will continue to die from rare and less common cancers in the thousands every year. The survival rate for breast cancer has gone from 60% in the 90s to 90% now, and this is amazing. But the survival rates for rare and less common cancers really haven't improved very much. The 5-year survival rate is still only 45%. Reducing budgets for rare cancer will only exacerbate this problem. This is what we mean when we say that we need to look again at the social contract. Cancer patients who paid their taxes faithfully for years should expect to have their right to the highest attainable standard of health upheld to the extent that distributive justice can do so. Sure, the government can't print money, or possibly they can, but they can't pay for every possible treatment for every rare cancer patient. But the government can do a better job of expediting access to medicines. The government can fund care navigators for every cancer patient. Medical professionals can stop being paternalistic, can provide patients with all the information they need to make informed decisions, and can involve them in decisions about their care and the care of others like them. And patients, let's be honest, patients are working bloody hard just to survive. And they need the government and the medical profession to work together and do their utmost to help them do just that. Before I finish, I'd like to quickly thank Dr. Chris Watkin from the Social Contract Research Network for his input into my preparation for this talk. And finally, to Rare Cancers Australia and all of the patients they represent for the opportunity to give this talk and wrestle with these very real issues.